So the last but not least, let's welcome Dr. Yang Yu. She is a medical microbiologist at Eastern Health, the Newfoundland and Labrador Public Health Microbiology Laboratory. And she also is a clinical assistant professor at Laboratory Medicine, Faculty of Medicine in Memorial University. So she will introduce the laboratory diagnosis of the COVID-19. 那么接下来呢，我们要重磅邀请的就是来自我们纽芬兰纪念大学的于教授，他呢是一位医学微生物专家，所以他接下来要跟我们分享的就是有关于实验室诊断的相关情况。有请我们的于教授。
So, hello everyone. It's really an honor to be here to share with you about some of my experience working in the lab for testing. So I'm going to talk about laboratory testing for COVID-19. Actually, would be more specific is for microbiology testing. We know that since December 2019, there are so many change and knowledge obtained about this infection. There's so many name change, including how the disease will be called and the virus causing this infection. So now we all know that it's called COVID-19. That's the disease itself. And the virus causing this infection is called official name SARS-CoV-2. And the name given because it shares a lot of genome similarity with SARS that caused the outbreak in 2002. Like if for those interested in learning about this virus, like 2019-nCoV was another name. If you do literally like search, remember to include that. So why microbiology testing is that important? The COVID-19 clinically is not specific. So that means you cannot tell from the symptoms or signs that this is a COVID-19. It has a lot of overlaps with other seasonal respiratory virus infection, including influenza. So it is very important to have a specific testing for the virus itself. It has some meaning in both individual level for the patient to be able to diagnose an infection and proper clinical management or infection control property could be applied to prevent any further transmission. At population or community level, it's very important to know the level of prevalence of the infection so that proper measurement policy could be also established. A lot of questions already. I see that people ask why, like we test that many, we test like in certain province, certain area, we test more, certain areas we don't. So the microbiology lab actually depends on the pandemic or the outbreak phases. There are different strategies. In the ideal world, if we don't have any limit, we can test everyone. But we have limited resources and we have to be smart. So during the early phase, it's called containment phase. It's basically we can test more. So we have more supplies, we can test more. So that's the time we probably also have less patients. That's why at the very early stage of the outbreak, we have a case definition. We say, oh, this is a patient with certain symptoms or signs and has a certain contact. But with more and more cases found out, especially there is a community transmission, you cannot test everyone. Then you have to be focused. So that's the time you have to decide. You test more patients that's severe, that they need to be hospitalized. And for certain patients that they are more vulnerable to have a bad consequence when they got infected. For example, those immunocompromised because of like cancer, chemotherapy, or some patient, they have family member in their family has that condition, or seniors in long-term care. In certain professions, like for example, the healthcare workers, you want to know they are not infected so that they can take care of the patient without getting the infection. So this is the reason why we test, and at a certain time we test more, a certain time we have to say, sorry, we cannot test you. So we all know that the COVID-19 is caused by this RNA virus. So this is a structure, so is RNA inside the cells, and with some structures, so all of them has some role to play, for example, to invade the human body and give infection, and some might be causing more production of but luckily also this different structure gave us a tool to test virus. So these are the various image that everyone familiar, but what really the virus look like, it's not that pretty. So these are the electron microscopic picture. So really proud that China CDC, they are the first one culture and isolate this virus from clinical specimen. And that's a picture they took January the 6th and published. So later on, more and more pictures and isolation. This is a picture also from China CDC from environmental samples. So how can we test this virus infection? Can we like look under the microscope? Can we culture? Unfortunately, that answer would be no. So first of all, to culture is really complicated, takes a long time, and more importantly, is of significant biosafety concern, because this is a virus causing really bad infection. We don't want to jeopardize the laboratory staff by doing that. So then the test right now used in clinical management, in community management, also folks know about the molecular testing. That is real-time PCR, and this is more or less considered a gold standard. And also more and more on the horizon, we know that people ask about antibody testing or the serology testing. But the question mark is means we don't know exactly how to use it yet, and how the performance of certain tests are, we don't know. We don't have much confidence yet. So this is a diagram about the molecular testing. You see that specimen collected, sent to the lab. The lab will use an instrument to try to get the RNA out of the virus, and then we'll use the PCR machine to amplify, and the signal is actually labeled, detected by a probe that give off fluorescence. So the machine will detect it and tell whether the virus is there in the specimen or not. There are a lot of specimens that could be used that we know this COVID-19 is more the respiratory tract infection. So that's like really no-brainer that to collect specimens from the upper respiratory tract, means the throat or the nasopharyngeal, or lower. When we're talking about lower, would be down to the bronch or the lungs, the sputum or BL would be the specimen. But as Anthony mentioned, that in the community, is more practical to collect the upper respiratory tract samples. More used would be the nasopharyngeal swabbing, so that's NPS. So you can see that this is a swab going down, and this is the tip of the swab to collect the specimen from there. And then there's also an option to get from the oropharyngeal, so that's through the mouth to collect the specimen. So there are different options when we have different swabs, and I'm not sure whether you're aware of that. There was quite a significant shortage of swabs to be used. So this is why there are a lot of work done to get specimen for the community sampling. So a lot of question about what would be the best specimen to give a higher sensitivity result. So these are the study, thankfully, to the Chinese colleagues. So they were able to compare different specimen types. So the bronch lavage or the BAL. So this is a fibrobronchoscopic brass biopsy. So these two are quite invasive methods, so it can be routinely done. And sputum also will be another way, but like they are all with concern to generalize droplets or aerosol to cause the collector to be infected. Commonly used ones, nasopharyngeal or pharyngeal throat, actually has relatively low positivity rate. So these are the questions people ask. There's a false negative. What that means, I saw some questions also. These are some of the local laboratory evidence. So this is actually one ER physician. So he was coughed into his face by a patient that's known positive. And then he actually kindly to offer help us, so to collect specimens. So March the 17th, so that's the time he was coughed on. And you can see, so this ND means not detected. So like in about 3 or 4 days, looks like there's not detected. And then we also ask him to like collect specimen differently. So this is NPS, so that's through the nose. And then this the deep nasal swab, that's just around the nose, the nostril, and the throat, and then the nose, the nostril, and then the sputum. So we just want to see the time where the virus could be detected. So looks like the change is quite significant. So so March the 20th is not detected. And then actually 1 day later, you see that the virus could be detected both like in all the sites. So if you see the blue triangle, so that's a sputum. So we don't have much specimen. So mainly like patient with COVID-19 infection, actually they don't tend to give a lot of sputum. So that's the reason. But you can see sputum is quite a good sample. It just came out late. So again, that reflects what Anthony talked about. So it looks like actually the infection started around the upper respiratory tract, and then it might move down to the lungs. So depends on the stage of infection, different size might give you different sensitivity. Hope this makes sense. Just a summary about around the molecular testing or nucleic acid testing. We have a lot of questions asked by the physician. So I put them here, thinking might be some questions also our audience might ask already. So like say we heard patient with COVID whose first test was negative, then they were tested again a couple of days later being positive, like how this could happen. So it could be happen when the patient actually just had like early stage infection, not a lot of virus yet. And it could be the first one when the sample was collected, not a lot of material, a lot of virus taken. So that could be the reason. This like made a lot of question like to like doubt about the result and make a lot of calls between the lab and the clinical. And then there's also another question. So why don't we swab asymptomatic patients? And I think Xie talked about like some exceptions that you will test some asymptomatic patients under certain circumstances, but generally we don't. More is we are still facing some shortage, the limit of resources. And secondly, we don't know exactly the performance of the test among the asymptomatic patients. So we don't know if we have a negative result, whether that's false negative. And sometimes this false negative result might give patient a really false assurance, oh, I don't have an infection. Then they will run out and potentially will give the infection to the others. So this is the other question asked a lot. Then there's also a question about the sensitivity of the test. So this also go back to the first question. So it depends on like when or how you collect the sample. And also because for the nucleic acid test or PCR test, so in a normal situation, actually any test that's been used in a diagnostic lab for diagnosis will go really straight evaluation by Health Canada. It's not easy to see a test in weeks get approved. So then that means the evaluation of the test performance is different. Sometimes you use a test that probably the performance is not that great, that would actually cause the sensitivity is questionable. And so another question we also got asked about if a patient has a negative test, what should I do? So always we'll say a patient with a negative test might means this patient had an early stage infection. If the symptoms still going on, there is this risk, then you will retest in 1 or 3 days. If you remember that ER doctor's curve, you can see that just in 1 or 2 days, actually the virus would give a really different signal to be detected. And or a patient could have a negative test, but then they might be at the very end stage of infection. So that's why it's a negative test. So this would be a good example when the antibody or serologic test would be beneficial. So this would then move to the next part of my talk about serology testing or antibody testing. So it could be like really simple, like cassette test, like or called point-of-care test, or it could be a really complicated instrument in the lab that can handle a lot of tubes to give antibody. Our body, when facing an infection, could it be a virus or bacteria or any other pathogens, produce antibodies. So the immune system will produce different flavor of antibodies. So IgG, IgM, IgA, like more used in, as we know them more, so they are more used in diagnosis or some immunity testing. For D&E, we don't know a lot. So just for the sake of this talk, the IgG and IgM like worked a lot, and there are more assays actually on the pipeline to be used, and there are also some testing about the IgA. Like again, so credits to our colleagues in China. They've done a lot of work that make our life easier. So they have done a lot of work to show that IgM, IgA, like both for acute infection, they produce within 10 days of onset of symptoms. And then it looks like after the infection continues, it seems they are not going to be detected easily anymore. Then IgG seems to kick in. Then like this is another curve to compare with the molecular testing. So that's the nucleic acid testing. This would be the antibody, and IgM is the red one, and the green one is IgG. You can see actually at early stage, you will see probably higher positivity rate using the nucleic acid testing, whereas at the later phase of the stage with the onset of the symptoms, you will see more and more antibodies could be used. So in this study, the basic conclusion is that the antibody, especially IgM, that happens at early stage of infection would be a really good supplementary part to increase the yield of detection. There is another paper actually just published yesterday, and also shows something similar. So if you see IgM, IgG, then after about 4 or 5 days, you start to see the titer coming up, and then you see more and more positive in the patient with the days of the onset of the symptoms. However, the meaning of antibody detection, as I mentioned, we are not quite sure yet. But from the study, the author mentioned that like it could be used as a complementary testing on top of the molecular testing. And this is quite in keep with the current Canadian agreement among the microbiology laboratory and also the WHO about the situation to use antibody testing. So it says it's still not suitable yet to be used as acute diagnosis for COVID-19 on itself. It could be used as a complementary for nucleic acid test, and there are a lot more we need to know about immunity of this virus. And so it is quite exciting field, is promising. We are hoping that with more and more knowledge, then we will be able to give a clear answer how to use antibody in the dealing with COVID-19 infection. But at this moment, it could be used, one potential we're talking about with our colleagues in the laboratory. So if a healthcare worker, if the IgG detect positive, that means this healthcare worker had an infection. So is lower risk to have another infection, at least so far, even though we don't know 100% whether they will reinfect, but at least means they are infected, so then they can go back to work. And especially facing the PPE shortage, some of the testing among healthcare worker would provide some information to decide and to prevent our first-line colleagues get infected. So that will be the end of my talk. I hope I gave you some information about testing, and any questions, please feel free to ask.
Thank you so much, Doctor. You have given us a very informative report about different types of the testing and the pros and cons for each. I think it is really, really important to have the microbiology testing. And thanks so much for sharing. And